Hello again, my name is John Tsai from the UCI School of Medicine, and in today's video we will be continuing our physiological journey through the kidney by talking about how our kidney creates the optimal pH for our body to continue to function optimally. To review, we have talked about salt and water regulation as well as the corticomedullary concentration gradient in our first video. We then talked about potassium regulation in our second video, and in this video we will be discussing acid regulation. In our next and final video, we will be discussing how various hormones are produced or play a role in the kidney, aside from its functions that we have described in the first three videos. While you will also learn about acid regulation in your pulmonary block, the renal acid handling is unique in that it's able to handle non-volatile acids, or acids that cannot be converted into carbon dioxide and be subsequently excreted through our respiratory system. Please note that interpreting acid-base disorders from blood gases will be covered in the next block. Let's first start by recalling where all this acid comes from. Acid is generated as a byproduct of our nutrient metabolism. Carbohydrates and fatty acids are generally broken down into carbon dioxide, and when excess amino acids are broken down, they are converted into urea and other acids such as phosphoric and sulfuric acid. Carbon dioxide is considered a volatile acid since it can be excreted as a gas, unlike sulfuric and phosphoric acid, which are non-volatile acids and cannot be excreted as a gas. The chemical equation here showing the combination of carbon dioxide and water to form carbonic acid through the action of carbonic anhydrase, which then gets broken down into a proton and bicarbonate anion, is a very important reaction that happens throughout the body. This process is very efficient and occurs in our capillary beds of our muscles and other organs that are generating carbon dioxide. The proton and bicarbonate that is soluble in the serum are then transported around the body to the lungs and kidneys where this chemical equation can be reversed. In the lungs, the carbonic anhydrase enzyme reverses the equation, forming carbon dioxide and water, again resulting in higher partial pressures of carbon dioxide in the lungs, which then eventually gets exhaled out of the body through the respiratory mechanisms you have already learned about. In the kidneys, these are generally excreted and filtrate, and then get processed in the tubules depending upon if we need to conserve bicarbonate or excrete bicarbonate. Hence, you can see that the carbon dioxide to carbonic acid and bicarbonate chemical equation is not only important at allowing movement of carbon dioxide to the lungs for excretion, it also forms a very important buffering system in our body. Since we are generating a lot of non-volatile acids in our body that can't just be excreted through our lungs, we must have buffering systems to prevent the buildup of this acid and the resulting damage that an acidic environment would cause to our cellular functions. While our cellular functions can adapt to fluctuations in pH, the pH range that cells can function properly is roughly around 7.4, but with extremes of life capable of handling a pH of from about 6.8 to 7.8. Interestingly, our cellular functions and systems are more capable of tolerating lower pH values or acidic environments compared to higher pH values or alkalotic environments. So why don't we become acidotic with all the acid being generated? Well, the most important and most abundant buffering system we have in our body is the bicarbonate carbonic acid buffering system. The bicarbonate anion that is produced in our kidneys, which we'll discuss later, is integral in mopping up the extra protons that are produced as acidic byproducts of metabolism. These excess protons can then be converted to carbon dioxide and water, or be eliminated through the kidney where another buffering system takes over that proton once it gets into the urinary space. That buffering system is the ammonia system and allows urine acidification to get rid of any remaining acid in our body. While the ammonia and bicarbonate carbonic acid systems are the most important in our body, we also have protein buffers, phosphate buffers, and even hemoglobin can act as a buffering system. But all of these play a much smaller role in acid-base handling compared to the first two. As a nephrologist, I like to think that kidneys are the most important organ, but I have to hand it to our pulmonary colleagues on this one. The lungs have a much higher capacity of handling acid compared to the kidneys and can affect pH values much faster compared to anything that the kidneys do. We will talk more about how bicarbonate and carbon dioxide levels affect pH in the next block. For now, I want you to realize that gas exchange is just so much more efficient compared to generation of bicarbonate and secretion of acid through the kidney, and it shows from these numbers here. The lungs can excrete about 12 to 13,000 millimoles of acid per day, compared to the palsy's 70 to 100 millimoles of acid per day that is excreted through the kidneys. During exercise or stress, even higher amounts of carbon dioxide can be generated and exhaled through our lungs, upwards of 20 to 25,000 millimoles per day. But as I said before, the kidneys are able to handle the non-volatile acids that our lungs cannot, and the two organs work together to effectively and efficiently maintain acid balance throughout our body. Now that we've discussed the interplay between pulmonary and renal, I'll let our pulmonary colleagues talk to you more about the pulmonary handling of acid, and we will focus on renal acid handling for the rest of the talk. Our kidneys generally play three important parts in acid-base balance. The first is that it recaptures all of the bicarbonate that is freely filtered through the glomerulus. The reabsorption process is similar to sodium reabsorption, where upwards of 80% of the filtered bicarbonate is reabsorbed in the proximal tubule. The remaining 20% is reabsorbed through the thick ascending limb of the loop of Henle, distal convoluted tubule, and collecting duct. In addition to reabsorbing the bicarbonate that is filtered through the glomerulus, our kidneys also play an important role at generating new bicarbonate through the breakdown of the amino acid glutamate. Lastly, our kidneys also manage acid loads by directly excreting fixed acids in the cortical collecting duct. I'll go over each of these processes more in depth in the coming slides, but realize that if any of these become problematic, we will eventually retain acid in our body and develop acidosis. Let's first talk about the reabsorption of bicarbonate. And remember that most of this process happens in the proximal convoluted tubule, which accounts for about 80% of the bicarbonate reabsorption. First, the filtered bicarbonate combines with a secreted proton from the proximal tubular cell and gets converted into carbon dioxide and water through the action of carbonic anhydrase 4 enzyme that is found on the luminal membrane. The carbon dioxide and water are able to freely pass through the cell wall into the proximal tubular cell, and then again gets converted to a proton and bicarbonate anion through the action of another carbonic anhydrase enzyme. This enzymatic activity lowers the carbon dioxide concentration in the cell that allows for more diffusion of carbon dioxide from the luminal space. Next, the bicarbonate anion then exits the cell into the blood space via the sodium bicarbonate transporter, or NBCE1. The proton gets excreted either through a H plus ATPase or the sodium hydrogen exchanger NHE3 that we had previously discussed as a method for sodium reabsorption in the proximal tubule. Then the cycle repeats itself over and over and over again with overall no net loss in protons. In the distal convoluted tubule and other areas of the nephron where bicarbonate is reabsorbed, the same process occurs but at a lesser degree compared to the proximal tubule. Next, let's talk about how we generate new bicarbonate that is used to replenish supplies that are lost. New bicarbonate is generated through the metabolism of glutamine, the most abundant amino acid in the body. Glutamine metabolism actually results in two very important things. The first, of course, is bicarbonate, and the other is ammonia, which is just as important, as we will see in the coming slides. For each glutamine molecule that is broken down, 3 bicarbonate ions are created and are transferred into the blood by our good friend, the sodium bicarbonate transporter NBCE1. The ammonium, or NH4 plus ion, is then either directly transferred into the urinary space by the sodium hydrogen exchanger NHE3. Alternatively, the ammonium NH4 ion can be separated into a proton and ammonia, or NH3, which is also transported into the luminal space via similar mechanisms. The details of ammonia or ammonium secretion are not necessarily important, but know that ammonia is secreted into the luminal space and will eventually act as a main urinary buffer, preventing our urine from getting to such a low pH that would destroy our bladder. Lastly, our body can get rid of extra protons in the distal tubule via 2 mechanisms in the alpha intercalated cell, the H plus ATPase and the H plus K plus ATPase. The H plus K plus ATPase is dependent upon potassium secretion from the ROMK in the principal cell. The ROMK, as you know, is dependent upon sodium reabsorption through the ENaC channel, and the ENaC channel is in turn dependent upon the presence of aldosterone. Hence, proton secretion through the H plus K plus ATPase is ultimately aldosterone dependent and will play a role in states of high or low aldosterone. So we can see here that in states of high aldosterone, this increases sodium reabsorption, which then increases potassium secretion via the ROMK. The extra potassium then stimulates the H plus K plus ATPase in the alpha intercalated cell to secrete protons, helping to eliminate extra acid from the body. We can also see that if high aldosterone is present either pathologically or due to high potassium levels in the body, then a secondary effect will be proton secretion, leading to lower acid levels in the body and higher bicarbonate levels in the serum, a state known as metabolic alkalosis. Let's go back to ammonia, and I want to preface this slide by saying that we don't know the exact mechanism behind the entire process, and much of this may sound very hand-wavy. All you should remember is that ammonium is created by the proximal tubule. After it's created, as we discussed before, the ammonium is then reabsorbed in the loop of Henle and then into the interstitium, and then gets re-excreted in the distal tubule in order to help absorb the protons that are secreted in the cortical collecting duct, as we discussed in the previous slide, via aldosterone and non-aldosterone mediated channels. Essentially, ammonia plays an important role at helping to buffer the urine to allow additional proton secretion from the distal tubule. I also want to say that in addition to ammonia, phosphate buffers also play an important role in urinary acidification, but its physiology is not really well defined yet either. I'm putting a link here to another website that discusses the process of ammoniogenesis and ammonia cycling if you want to know more about this process. Now I just want to go over what happens when we have any derangement in any of these physiological processes that we just talked about by talking about an important pathological issue called renal tubular acidosis, or RTA. If we have any issues with the reabsorption of bicarbonate in the proximal tubule, that results in bicarbonate not being reabsorbed either through the NBCE1 transporter or the NHE3 channel, we call this a proximal RTA, or a type 2 RTA. This is called type 2 non-intuitively since it was the second type to be discovered. If we have a problem with proton secretion in the distal tubule in the alpha intercalated cell, either through the H plus K ATPase or the H plus K plus ATPase, then this is called a type 1 or distal RTA. And if you have a problem with aminogenesis, or if you have an aldosterone issue, either in the production of aldosterone or resistance to high levels of aldosterone, then we call this a type 4 RTA. There is one additional type of RTA called a type 3 RTA that was discovered to be actually a combination of type 1 and type 2, which is due to defects in carbonic anhydrase 4 enzyme found on the luminal membrane, and it's common to both the proximal and distal tubule, hence it's actually a combination of the two types, and is not technically considered one of the proper RTAs anymore. This table summarizes all the electrolyte findings in the three types of RTA. Please remember this important information highlighted in red here, as this will help you distinguish between the three different types of RTA quickly. Remember that all of them will produce varying degrees of acidosis, so the serum bicarbonate will be low. In addition, since the proximal and distal tubules are also important in reabsorption potassium, the type 1 and type 2 RTAs will have low potassium levels of hypokalemia, while type 4 will have a high potassium level since there's usually aldosterone resistance or insensitivity, preventing adequate potassium excretion in the distal tubule. For this reason, type 4 RTA is also called hyperkalemic RTA. Now, why does type 1 RTA have a lower bicarbonate level but a higher urine pH compared to type 2 RTA? The reason for this is because proton secretion is impaired in type 1 RTA, but not type 2 RTA, which allows for urine acidification to occur when it comes to type 2 RTA. There are actually some slight variations to these RTAs that can occur, but this high-level overview will be the extent to which you are responsible for this information. Now, how do we define or find these cases of renal tubular acidosis? These are actually fairly rare, but potentially if you look more for them, you might find them that they are more common than you expect. The first clue is to look for that low bicarbonate level. Low bicarbonate levels can mean one of two things, either a metabolic acidosis or a respiratory alkalosis when the kidneys compensate by eliminating extra bicarbonate from the body, resulting in lower bicarbonate level. We can use an ABG or VBG to confirm the presence of metabolic acidosis or respiratory alkalosis in ways that I won't go into in this lecture. You will go over interpreting blood gases in the next block in more detail, but in this block we will help you identify the metabolic acidosis or alkalosis process. We will also be going over more in-depth causes of high anion gap versus non-anion gap metabolic acidosis in the next block too, so don't worry too much about it for now. However, the red highlighted equations here on this slide are important, and you should memorize them for this and the next block. Once we determine we are dealing with a metabolic acidosis, the next step is to determine if you have a high anion gap metabolic acidosis or a non-anion gap metabolic acidosis. We calculate the serum anion gap using the serum sodium, serum chloride, and serum bicarbonate, and if the equation sums up to higher than 12, then we are dealing with a high anion gap metabolic acidosis. If the value of the equation is 12 or lower, then we are usually dealing with a non-anion gap metabolic acidosis. Once we determine that we are dealing with a non-anion gap metabolic acidosis, we can then calculate a urinary anion gap, which is calculated as the urine sodium plus the urine potassium minus the urine chloride. If this value is negative, then it is more likely a GI cause that is causing the metabolic acidosis, whereas if the urinary anion gap is positive, we are usually dealing with a renal cause, possibly an RTA in this case. So you can see from here that there are a lot of steps to formally diagnose somebody with an RTA, and once you become more familiar with the laboratory test, it does get easier and easier with practice. I also wanted to stress that RTAs are usually due to channelopathies or tubular issues in the absence of chronic kidney disease. The presence of chronic kidney disease is usually associated with a metabolic acidosis for the sole reason that there is low nephron mass, resulting in essentially all the different RTAs and not a specific RTA in particular. Hence, please ensure that the patient has normal kidney function before diagnosing any RTA. Let's review today's material with another diuretic that we used called acetazolamide. Acetazolamide works by binding the carbonic anhydrase enzyme in the tubule, especially in the proximal tubule. It works as a diuretic because bicarbonate usually is associated with a small sodium molecule in solution, and if we aren't able to convert bicarbonate to carbon dioxide and water, we get bicarbonate wasting or bicarbonaturia, basically bicarbonate in the urine. This leads to distal sodium delivery and eventually sodium wasting that leads to its diuretic effect. Now remember that if we block carbonic anhydrase, this will result in a type 3 RTA, or combination of both type 1 and type 2 RTAs that I discussed before, since it acts in both the proximal and distal tubules where carbonic anhydrase sits, and eventually this leads to a lower bicarbonate level in the blood, hence the acidosis. This is a medication that we don't want to use on somebody with normal issues, but in the case where we have high bicarbonate levels in the blood, or alkalosis, you can see that this medication will be very helpful to correct this alkalotic state and bring the pH back to more normal levels. Now, I want to talk about a physiological state that we can use this interesting medication for on the next slide. One other use of acetazolamide is in prevention of altitude sickness. How does this work? Low partial pressures of oxygen at high altitude levels induce hyperventilation. As you may recall from your pulmonary lectures, hyperventilation results in lowering the PCO2 levels in the lungs and the blood, which usually causes a rise in pH. Usually your kidney can help compensate for this rise in pH by getting rid of bicarbonate. However, this process lasts on the order of 3 to 5 days. This is the main reason why acclimatization to high altitude is necessary for your body, and you should usually go up a tall mountain very slowly. However, there are some situations where you can't wait, such as a direct airplane flight from a low altitude area to a high altitude area. In these cases, acetazolamide can help by basically bypassing your body's slow response to low PCO2 levels. Acetazolamide induces a metabolic acidosis by getting rid of that bicarbonate, so that when you do go up to higher altitudes, your pH doesn't rise to the levels that would cause you to feel ill. The induced metabolic acidosis is also helpful in that it increases ventilation and oxygenation in the body to compensate for the low oxygen concentrations at higher altitude. There was a lot of information and material today that we covered in this video and in previous videos, but let's summarize with a case study when medications we give can cause more problems than we actually are trying to fix. Cisplatin, a chemotherapy agent used in many different forms of cancer, and tenofovir, an antiviral agent used in the treatment of HIV and hepatitis B, has the known side effect that it can cause damage to the proximal tubular cells. This destruction of the proximal tubular cells results in a lot of different electrolyte arrangements, since you recall the proximal tubule is responsible for a reabsorption of 60 to 70% of all the electrolytes that are filtered through the glomerulus. Knowing how the filtrate is now processed from the proximal tubule all the way to the distal tubule, can you predict what happens to sodium, bicarbonate, and potassium levels in the body when these medications do cause damage to proximal tubular cells? Pause the video here to think about this case, and click play when you're ready to hear the answer. The destruction or inhibition of proximal tubular cells causes a constellation of issues called Fanconi syndrome. And if you remember what the proximal tubular cells do in the kidney, you can predict what the effects are for Fanconi syndrome. With regards to sodium levels, it actually doesn't result in sodium wasting, but remember, we have the loop of Henle in the distal tubule to make up for the sodium reabsorption problem, so we usually don't get any issues with sodium levels in our body. When it comes to potassium, Fanconi syndrome can cause problems due to potassium wasting and can cause hypokalemia. With regards to bicarbonate, Fanconi syndrome causes a type 2 RTA, which results in low bicarbonate levels in the blood, but since distal proton secretion remains intact, the pH of the urine remains low due to the distal proton secretion processes remaining intact. Additionally, proximal tubular abnormalities cause glucose wasting or glucosuria, phosphate wasting or phosphaturia, and sometimes proteinuria, which are all hallmarks of Fanconi syndrome. That's all I have for you guys in today's video, and as usual, I'm leaving you here with some additional resources for you to learn more that I'll put here in the description below. Please join me in our next video as we discuss the hormonal aspects of renal function.